What is this? It's a long artery forceps, okay? Huh? Where do we use artery forceps? To hold the vessels, no? Okay? And then you can even hold the sutures, no? Okay, hanging suture, okay? And this Alice tissue holding forceps, tough structures you can hold. Or what is this? Yes, you can hold the tough structures and the angles of the uterus, okay? This looks like a sponge holding forceps, but this is a chisel forceps. Why is chisel forceps used? So that infection prevention standard is maintained, no? Because whatever you take out from that clean one, you autoclave, sterilize, you take it out from this, because this will be clean, okay? Autoclaved. This is forceps, and again dilator for gynae, no? And this is episiotomy scissors, okay? What is episiotomy? You have to know what structures are cut in episiotomy, which is the most common episiotomy given, what is the complication of episiotomy. Okay, and these are the different cannulas, no? According to the weeks, this cannula also is, some are big, some are small. For small you use small cannulas, for big you use big cannulas, okay? Where is the coccus forceps here? Instead of keeping it here, it's kept there. Oh? Okay. Okay, this is coccus forceps, it's very tight. Where is it used in labor room? To do ARM. Where else can we hold it? If there is tear, 3rd degree tear, no? Or 4th degree tear, to hold the sphincters. You can hold the sphincters with this, okay? Then what else? Now this is the forceps.
Regulus forceps.
Optic outlet forceps. So what are the parts of the forceps? Blade, shank, handle. And then there is left blade and right blade. Where is the left blade? It should be like this, no? So this is not a... How do you know which is left blade? So it's like this, no? Whichever blade shows concavity inside, pelvic curve forward, tip upwards, you know? So this is the left blade and this is the right blade. Right blade. So which blade do you put first? Left blade first, okay? Left blade first, then right blade. Then while removing, the right blade is removed first. No? What are the indications of using forceps? No? What are the prerequisites for using forceps? Go and read. No? What is the advantage of forceps over vacuum? What do you think is the advantage? This is a light instrument, you can just carry it anywhere, and then it doesn't take time to cause traction. In that you have to create a shigon, no? So it takes time. So this is better for cord prolapse and fetal distress, better than that. Okay. But what is the disadvantage? Trauma, maternal trauma is more, and then it needs skill, and then training is more needed than in vacuum. Okay, because the space occupying, so it can cause maternal tissue trauma because it goes inside, no? And this is vacuum. Ventose, okay. And then with what is this made out of? What is this? Is it metal? Then what is this? Huh? What double valve? Who is saying double valve? Just saying stupid things. What is this made out of? Huh? Yes. Okay. What is the advantage of vacuum over forceps? It can be. It doesn't take much time to learn, no? So not so much skill is needed as it's in this process. What else? Advantage of vacuum over forceps?
Maternal distress, it can be used.
Huh?
Maternal
Okay, maternal distress, very good. Then what else?
lethargic mother.
Huh? Okay, lethargic mother, no bearing down effort. What else? It can be used in fetal distress all also, but that becomes faster, no? Huh? What is the other advantage? Okay, non-trauma to the mother, but more traumatic to the fetus. Okay, because this is not space occupying, only this much, whereas forceps is a big thing, no? Huh? So, what are the complications to the fetus it can cause?
Headless.
Cephaly hematoma. So learn the difference between cephaly hematoma and captive subsidiary. Okay. And what is the disadvantage over this? This can be even used in premature fetus, but this one cannot be used. This can be used in
Malpresentation.
after coming head of a breech, in minto anterior, no? This cannot be used in such conditions, okay? Now this is a pelvis, maternal pelvis, female pelvis. So when you say keep it in the anatomical position, you will keep it like this. You will keep this higher than this lower. Now you have to know the boundaries of the inlet, no? Okay, and boundaries of the least pelvic dimension. So what is the obstetric importance of this least pelvic dimension? That you have to read that 4-5 points, no? What? Station, no? If it is up, it is -1. If it is at the spine, it is 0 station. If it is at the lower, it is plus station. And what else? Pedental nerve is given in this level. There is internal rotation. The levator ani muscle originate from here. Then the pelvic axis goes forward in this. So these are the obstetric importance. Then you have to know about the sutures, no? This is sagittal suture, this is coronal suture, this is frontal suture, this is anterior frontinel, this is posterior frontinel, function of the sutures and the frontinels, okay? Then the diameters of the fetal head. Here also you have to know anterior, oblique, lateral, all this. Interischial diameter, no? You should know. And then here, what are the 9.5 centimeters, 3 diameters in the fetal head? BPT, suboccipital bregma, suboccipital bregma is in the occiput, no? From here to here is suboccipital bregma, and submental bregma, 9.5 centimeters. No? Then other diameters also you have to know. Okay. Okay. Now you go and read. No. Then let's see what is that. What is this? Listen. Okay. It is F2 alpha. It is given intramuscular or direct intrauterine in case of PPH. How many doses can be given? 5 doses every 15 minutes. I don't know whether they'll ask or not, no? For PPH. What is this? Read, I cannot read. Okay, this is dexamethasone is given for lung maturity in preterm babies. Huh? In preterm when it is not term. Okay. What is this? Folic acid?
Yes, ma'am.
Folic acid is given to prevent neural tube defects. Huh? And this is isoxsupreme. What it is used for? As a tocolytic for premature uterine contraction when the baby is not term. Now this is condom. I don't know why it's kept here. What is this? Misoprostol. Okay, where is misoprostol used?
Abortion.
For rightening of labor, not induction. For rightening of cervix.
Rightening of cervix.
Okay, rightening of cervix. Then
Abortion.
abortion. Then in PPH. In PPH you use 800 microgram. Okay. In abortion, what drugs do we give?
Mifepristone and
Mito
misoprostol.
what?
Mifepristone and misoprostol.
Mifepristone. Okay. Mifepristone is given orally. 200 milligram. Followed by 24 to 48 hours. Misoprostol 800 microgram. Vaginally or cervically. Okay. And this is iron tablet. In anemic patient you give. No. And then in PPRM we always give for 6 weeks. But if it is anemic, we give for 12 weeks and 2 tablets instead of 1 tablet. What is this? Oxytocin. So it's used for induction of labor. Then
Augmentation of
labor. Then
Right.
PPH.
PPH.
Then third stage management, active management of third stage. So first is 10 units I am giving after the baby is delivered. Then control cord traction. Then uterine massage, active management of third stage. This is magnesium sulfate, I think, no? Yes. So you should know the Pritchard regime, no? How is the loading dose given? How is the maintenance dose given? No? And then you have to know what parameters are seen. What parameters are seen before giving the
Urine output.
Needs of urine output and
Respiratory.
Huh?
Respiration.
Needs of
Respiration.
respiration.
yes, 12.
Okay, this is for anencephaly because there is no brain and the skull. Huh? What defect it is? Neural tube defect. Which other neural tube defect you know? Spinal bifida, meningocoele, and what about hydrocephalus? Is it a neural tube defect? No. Is this compatible with life? No. It becomes alive for a few hours, sometimes for a few days. That's all. No. Okay. What is this? Ruptured uterus. Is a ruptured uterus complete? So, what is ruptured uterus? No. What is complete rupture? What is incomplete rupture? What are the causes of ruptured uterus? That one is hydrocephalus. Huh? Okay. Is it compatible with life? Yes. No, compatible with life. Then which surgery is done? Shunting operations are done no? From the ventricle either to the peritoneal cavity, but now they are even doing to the pleural cavity. Okay, and that is a placenta. Now placenta has how many surfaces? Which surface is this? Maternal because of cotyledons. So what's the normal weight of the placenta?
500 grams.
Okay. Then what is the normal attachment of the cord? The cord is attached in the fetal surface, no? Normal attachment, abnormal attachment, types of placenta and function of placenta. Okay. Then this is partograph. You all know, no? What is the advantage of putting partograph?
Identification of
Not only vital signs, you get the information in a single
progress of
fetus and mother. And what else?
Easy to handle the.
Okay. Easy to give handover. What else? The main is it helps in the clinical decision making when to augment, when to induce, when to terminate, no, because it tells you this if you maintain this, right? Okay. These are the one. Then sometimes they will ask you, what presentation is this? What will you say? Cephalic. And then like this? Breech. And in like this?
Transverse.
So they might ask you the mechanism of labor, okay? And what are the complications of breech? What do you think is the complications of breech? Operative surgery is done more than cord prolapse, all this, huh? Obstruction where? You mean to say after coming here gets? Huh? What obstruction? No, okay? Okay, now I've told you what to read, no? Can't teach all the things now, no? So, okay, all the best.